Sorry. Um, we'll talk about SVT and VT. For bradyarrhythmias, I'll spend some time talking about heart block, and then we'll talk about PACs and PVCs. So arrhythmias are a huge topic. Definitely, we could spend all day long talking about it. People go to specialized fellowships for this. So they're pretty diverse. They um, are diverse in and of themselves. There's different subtypes of them. And then there's also um, plenty of ways that they present both to us like versus in symptoms and then also just with other sorts of findings that we have just even on our cardiac rhythm monitors. Um, the confusing parts can be not only that they have some overlapping symptoms and not consistent symptoms with in and of themselves, but they can also overlap with normal heart racing or heart slowing type of symptoms. Um, I think that arrhythmias, even for us, are scary because I think the thing that we all want to do is to prevent something scary or horrible from happening. I think because of how um, diverse the presentation can be, and also the possible implications, arrhythmias can be a scary thing to try to sort out and understand for a patient. I do think, though, that the details can be sorted out and patients can be effectively triaged with a good history, examination, and EKG. So, with just very basic things that I think most of us all have access to, whether it's in our clinic or in a nearby hospital, I think that we can usually have a good starting point with all of those three things in terms of trying to sort out arrhythmias. And I think, we talked about the different things that we're going through in terms of the aims of this presentation, but I'm hoping that we can also try to work towards increasing our comfort levels with arrhythmias and then also encourage people to also, if they feel comfortable, start a workup for arrhythmias as well. Sorry, my roller on my mouse is not that great. All right, so I'm going to start with history. So I think history is really key in terms of sorting out arrhythmias. And so I'm going to spend some time talking about the common symptoms that we see, I think, with arrhythmias and that we're trying to sort through to determine if they're arrhythmia related. So I'll talk about palpitations and syncope, and then also talk about a few other signs and symptoms that I think are potentially important to sort out and recognize. So palpitations. So the general definition of palpitations is a feeling of abnormal heartbeat. So very, very general. Super common. I bet most of us on this presentation that are in the audience and myself included have had palpitations from time to time. I think that it's a super common thing that as kids are learned and teenagers are starting to understand their bodies, will feel from time to time too. And so it's a pretty common complaint, but I think that there are different things, and this is definitely not an all-inclusive list, but there are different things that I think about that I think align more with an arrhythmia versus not. So sort of, I made this table to just sort of sort through that. For descriptions of palpitations and that are more concerning to me. So, and a lot of this is more related to tachyarrhythmias, but when I'll have people, start from just like really walk me through an episode if they're able to. And as they start to talk about the episode, or after they're done talking about it, I will ask them, like, does the heart racing, for example, does it start all of a sudden? I'll use words like, does it start all of a sudden, like you're turning on a light switch? because arrhythmias typically, there are some arrhythmias that will gradually increase in rate that are pathologic, like ectopic atrial tachycardia, but most of them will have some sort of paroxysmal onset. And they will also suddenly stop too. So I'll, also ask about how the arrhythmia closes. Like, does it, or how does the feeling of heart racing, for example, how does that stop? Does it slowly stop over a few seconds, or does it suddenly stop, like you're turning off a light switch? If they have that sort of description that it suddenly starts or stops, that's definitely a little bit more concerning for an arrhythmia, but doesn't necessarily, and vice versa. If they, for example, describe that the heart racing gradually starts and stops, it doesn't necessarily rule it out either, but definitely a good clue. Um, I do pay a little bit more attention if the heart racing lasts for a longer duration compared to a shorter duration. And then I also try to tease out modifying factors as well. So, for example, a little bit, maybe a little bit less concerned if someone is describing that they feel heart racing. That happens with maybe standing up too quickly after they feel dizzy, or if they're feeling heart racing with exercise. Uh, there are some arrhythmias that can be triggered by adrenaline that you might feel with exercise. So as best as possible, I try to tease out, does this feel like abnormally too fast? And some people are able to describe that or kind of classify in their minds about whether or not that's it feels too fast, or if this is like the normal heart racing that they feel with exercise, for example. Um, for whatever reason, younger children obviously will have a limited vocabulary to describe heart racing, for example, or abnormal heartbeats. For whatever reason, I think it's really cute. But anyway, for SVT, a lot of the younger kids will describe that their heart is beeping. So that's another thing that kind of raises my suspicions of something that could be going on in terms of an arrhythmia in a child that's on the younger side. Um, I don't pay I don't really expect people to like sit there and count their heart rate during an episode, though that's definitely helpful if that's possible. And more we're able to do that with like technology. If the heartbeats are within the normal expected age, heart rates for age, obviously worry a little bit less about that, and vice versa. If it's SVT, that might be more of a description that it's like too fast to count. Like that's a common description that I will get as well. And then I think family history is also helpful. So I definitely would pay a little bit more attention for a possible arrhythmia if there's a family history of sudden death or even fainting that's concerning.
Before you go on,
Yeah.
Melissa, there was one question in the chat. Would you be
Mhm.
able to define what you mean by like a longer versus a shorter duration, please?
Sure. Yeah, I left it kind of general. So longer duration, like I think shorter duration, like if it's like a few seconds, probably wouldn't worry too much about it, unless it's like a really bothersome symptom for them.
Thank you. So minutes to hours would be longer duration then.
Yeah. Yeah, I think minutes to hours. Yeah.
Thank you. Appreciate it.
Yeah, thank you. And then fainting. So fainting is another relatively common symptom that, I mean, my vision is a little bit skewed in cardiology, but that we commonly see, I would say, especially in our teenager population. Thankfully, usually it's not due to an arrhythmia. So usually it'll be due to the, benign autonomic reflex mediated syncope that we usually hear about, where, it's after a quick position change, for example, or maybe triggered by something like receiving a vaccine. Um, so, that's again where details about the episode are very important. Things that make me worried for a possible arrhythmia being related to syncope. So if there's no prodrome, so if there's no like preceding dizziness or anything, then that's definitely a huge warning sign to me. I didn't list it here, but if someone's describing that they feel like a fast heart rhythm and then suddenly they don't remember what happened, that's also probably a worrisome sign. Though you would have to also tease out, like, were you feeling dizzy? What were you doing at the time? All of those sorts of things. Um, syncope during exercise is always a worrisome thing too, though also have to sort of sort out like, what exactly were you doing when when you fainted or when you started to feel dizzy. So if it's the type of dizziness and fainting that happens after, for example, um, sprinting and then suddenly stopping, that's goes back into the benign autonomic reflex mediated syncope. And then, I do pay a little bit more attention to fainting in my pediatric population or pediatric congenital heart disease population. So, for example, in patients that have a history of tetralogy of Fallot that was repaired, like those are patients that we do monitor possible arrhythmias, including ventricular arrhythmias, pretty closely. And so, syncope in that population, for example, could be worrisome. And then, this list of symptoms is not all inclusive, but other things that could be tricky to sort out. So, heart failure type symptoms, which can sneak up on us, are also worthwhile to pay attention to. And unfortunately, they're pretty nonspecific. So, fatigue, undue shortness of breath with activities, swelling may develop in certain areas. This again, you could have all kinds of other things like decreased appetite, nausea, vomiting, diarrhea, all of those sorts of things unfortunately can fit under heart failure. In infants, you might see poor feeding, and then for again, going back to our infant population where they can't talk about what they're feeling, so poor feeding, irritability, those might be some possible signs of an arrhythmia as well. So, in terms of testing, so I think that the wait to get into cardiology clinic can sometimes be a little bit long, unfortunately. So I think it's always worthwhile to consider doing a baseline EKG. You might discover something that you wouldn't otherwise see. So, for example, I have a picture of WPW here, where you can see that delta wave here in really all of the leads. So, if someone is complaining about heart racing and you get an EKG and they have this, like we would definitely pay a lot, like be much more concerned about a possible SVT in that scenario complained compared to like a completely normal EKG. We had a patient that presented a couple years ago also that had presented with fainting and then he got an EKG and then he had found out that he had long QT syndrome. So, I think it's always worthwhile to consider getting an EKG. And usually hopefully it's an accessible test for most of us to obtain. I think that it's also worthwhile to get labs too, especially for some of our tachyarrhythmias or for some of our like more nonspecific types of symptoms. For example, like it's just like your baseline labs like a CBC, BMP, um, uh, and then uh, yeah, I would just even start there or thyroid panel, things like that. Those are some things that you could get. Um, and then I think those are within the purview of the general practitioner. At this point, cardiac rhythm monitors, at least for our pediatric population, are mostly available just through our the pediatric cardiologists. So I think that if you're interested in a cardiac rhythm monitor, usually that or think that a patient might benefit from one, usually a cardiology referral would probably uh, coincide with that. But you can also, we've had general practitioners ask if they can send them, if they feel comfortable, send them to our clinic for a monitor. And we can have a conversation about that in terms of, what monitor would be appropriate, and usually what would happen in that scenario doesn't seem to happen that often that we get approached for this, but if we could interpret it and then send you back the results and then have you call the patient to discuss them. So anyway, usually at that point, that's when we get the referral for a concern for a possible arrhythmia. There are different types of cardiac rhythm monitors. There are the ones that we most commonly use are continuously recording the patient's heart rhythm. I have some examples of a cardiac rhythm monitor in the next couple of slides. There's also event monitors. We don't tend to use those as much, but those are used for more episodic events. So, you need to keep the monitor near you, and then when the event happens, like you put the monitor close to you, and then it records the heart rhythm. Um, and then for people that have events that are concerning but rare, sometimes we do talk about smartphone adapters. There's a bunch out there on the market. There's only, I think, one that I personally know of that's like FDA approved, and I don't have like the best confidence in it, honestly. But there is one that you can use to attach to your smartphone basically and record your heart rhythm. And then there are also the electrophysiologist can also place an implantable loop recorder that can be present for years in a patient to record their heart rhythm. And then sometimes I see this ordered for concern for an arrhythmia. I don't particularly think it's useful as a first line test, but an echocardiogram, you know, um, yeah, I just think it's focusing on the EKG and heart rhythm monitor devices is probably the better way to go. We do often get an echo eventually, but usually it's more to rule out structural heart disease, or if we're concerned about heart failure type symptoms, then getting an echocardiogram in that context might be helpful.
Do you mind if I interrupt with another question from the chat? Um,
Hmm.
Renata wanted to know, excuse me, if the over-the-counter Cardiomobile is used in the peds population. She said she thinks it's not FDA approved right now.
Um, I think that was the one that the cardia
Yeah, with a K.
monitor. Yeah, I think that I thought it was. Well, anyway, I
That's the
that's
one
the
you were
one
just
that I
talking
that's the
about.
one that I've been telling patients about. I thought the last time I checked it was, so I apologize if I'm wrong about that. But that's the one that I've been telling people to get.
Got it. Thank you so much for
Yeah.
clarifying.
Mhm. So this is the one that we commonly use. Just to give an example of a monitor, not trying to advertise for it or anything, but so this is what, when I started training, like it looked like a Walkman, and you had to attach the like 3 or 4 EKG leads to the patient, and then they carried it around with them on a belt. So now the ones that we more commonly use are basically a big sticker, and that's what I describe to patients. And so this is an adult patient, obviously, but so you can get a sense of how big it is. And then I have it here too. It's pretty small. The sticker part of it is big, but it's like a couple of inches, 2 to 3 inches. And it's pretty flat too, so it usually fits under clothing pretty well. And then you just like leave it in place for 2 days, a week, 2 weeks. Probably the most common complaints that I get about it is the adhesive. Over time, especially if you're wearing it for a couple of weeks, it does get to be irritable, especially in our humid weather. So oftentimes I'll have patients that aren't able to keep it on for that period of time, but we just ask patients to try their best with that. And then if you can see in the middle of both of these monitors, there's a button that you can press in order to activate the monitor. So these monitors are continuously collecting the patient's data in terms of their heart rhythm. But if you press the button in the middle, then you can also correlate their signs and symptoms with their heart rhythm. So, for example, if they're coming in complaining of heart racing or palpitations, I ask them to press the monitor when they have an episode, and then it flags that area, and then we can look a little bit closer to see what's going on and see if there is an arrhythmia that's correlated with it or not, and then provide some reassurance if it's not. And then just to give you an example of some of the information that we get from these monitors. So this is the front page that we get from them. We get some information about the heart rate range, the average heart rate, some of the EKG intervals as well, the burden of different arrhythmias if they're present, and some basic descriptions of them. Uh, we have some summaries, and then we can also see like the amount of times the patient triggered the monitor and what it correlated to. So that's our baseline page that we get. And then here over on the right-hand side of the page, we also can see over time, like what the patient's heart rate variability is like here. So for this patient, for example, his heart rate does go up and then down, up during the day and has some pretty good variability there, and then goes down as we would expect or at night when he's sleeping. And then you can also get a sense of where they're triggering the monitors. So, um, and then we have like a list of strips that are also printed out. So the person that's going through the whole like week or 2 weeks or 2 days of data will pick out certain rhythm strips that are representative of the findings. And then, so for example, in this bottom right example, this is an example of the patient's atrial tachycardia here. Um, but they'll also print out the strips of or some at least some of the strips of um, the episodes that the patient triggered, so that we can take a closer look as well. Um, we definitely have had like toddlers that have pressed it like 200 times, so not all of them will be printed out. But the company does a pretty good job of printing out like a representative selection of them. Right, so those are some thoughts about signs, symptoms, and testing. I'm going to transition now into talking about the various types of arrhythmias. And this is all pretty general. Um, I won't go into some of the subtypes of each of these, but just to give you a flavor of them. So starting off, we'll talk about some of the tachyarrhythmias that we see. We'll talk about SVT and ventricular tachycardia. And then I'll start with SVT. So this is our most common tachyarrhythmia in pediatrics. Um, so in terms of the presentation, so typically like this is a paroxysmal or sudden onset and offset. Um, that's a pretty classic description of SVT. And the reason why, we have a paroxysmal onset or offset is that typically, like 90% of our SVT types are due to a re-entry tachycardia, where the cardiac electrical activity is re-entering through the AV node and causing that cycle that generates SVT, or that super fast heart rhythm. In general, not always, but in general, SVT has a heart rate where the heart rate is above what is the peak expected for age or is too fast to count. Again, in smaller kids, like I would say in like preschool age kids or kindergarten age kids, they'll say that their heart is beeping. That seems to, I don't know, they all seem to say that for some reason in that age group. Um, and then you can have other symptoms that go along with it as well. So an infant, for example, may have irritability or poor feeding. They may appear pale. If it goes on for, usually it's well tolerated for a while. So, but if it does go on for a while, or if it's happening frequently, you might have some pallor, um, increased work of breathing. It may cause some dizziness as well, especially with activity. And then syncope or sudden death. There have been case reports, I think, of this, but it is typically rare. And then just an example of SVT here at the bottom. So you can see that this patient's heart rate is in the upper 200 beats per minute range. It's a narrow complex rhythm. I don't see any P waves here. Sometimes you can see that, just depending on the mode or the different subtype of SVT. But this is a pretty classic example of SVT here. In terms of workup, so um, I think that, referral definitely, if you're worried about SVT or any possible arrhythmia, is obviously appropriate. I think you could still start the workup by getting an EKG if you're if you are questioned. I don't always get labs, but if you are wondering if the presentation could be sinus tachycardia, it doesn't hurt to get some basic lab work, like a CBC, a BMP, thyroid studies. And then I think it's also okay to tell patients that, because what we're really trying to do, after we hear about the symptoms and we're trying to figure out what's going on, is to try to capture the heart rhythm, the fast heart rhythm on like an EKG or monitor. So I think that if, while they're waiting for their cardiology appointment, I think it's also appropriate to tell them that, hey, if this is going on and it's not stopping, like, please consider stopping by like going to the ER to see if we can capture the rhythm. Um, we will, try to place a cardiac rhythm monitor or do an event monitor for patients that have concern for SVT. Usually it's one of those continuous monitoring kinds of monitors that I just showed you, just because they are, I think, most user friendly to use. If they're not I try to match the duration of the monitor for the frequency of these events. So for example, if they're happening several times a week, then, we'll try maybe like a week or 2 weeks. For those events that are less often, like say like once a month, we talk about maybe doing an event monitor. And sometimes with the caveat that we may not capture one of those events. I haven't recently sent someone for an implantable loop recorder, though that's also a possible thing for someone that you're really worried about an arrhythmia that doesn't happen that often. And then again, we talked about those smartphone adapters as well. Um, usually after I've established that they do have SVT, that's when I will send, unless I'm worried about like some sort of heart failure type picture, that's usually when I'll send them for an echocardiogram. So most patients that have SVT will have a structurally normal heart, but having an arrhythmia is someone that has a structural heart defect is more likely to have an arrhythmia. So I will get an echo just to rule out structural abnormalities and evaluate heart function. And then treatment. We talk about episodic treatment of SVT and then also long-term options. So for episodic treatment, so we talk about vagal maneuvers. There are different vagal maneuvers for different age groups. So the hope with vagal maneuvers is that you're going to slow conduction through the AV node and therefore break the cycle with SVT. So with infants, I ask parents to keep like a Ziploc bag of ice in their freezer. And then if they're worried about SVT, like cover it with a dish towel or something and then place it on their face for like 10 seconds or something like that. And then take it off and then calm them down and then reassess their heart rate after that, and attempt that maybe a couple more times before considering going into the ER. For younger children, for those that you can hold upside down, that also seems to be effective in terms of vagal maneuvers. And then older children that can follow directions to bear down, then we kind of talk about that. I'll typically tell them to blow on their thumb as hard and as long as possible and to simulate that sort of feeling like they're pooping. Um, and then, I tell them that they can try to do this like a couple of times, maybe separated by about 5 minutes or so. And then if they've tried this and it's been like 15 minutes or so and they're still in this fast heart rhythm, or if they look unwell at any point along the way, then to go to the ER because they might need adenosine. And adenosine works in that same sort of way where it transiently slows conduction through the AV node to hopefully break that cycle of SVT. Um, so that's episodic treatment. In terms of long-term treatment, so if it's not that bothersome to people, I tell them that there is an option of doing nothing about it. If they feel like they can handle it, they're not that worried about it. Um, Say they're not going to the ER every month or something like that. Some people will choose to just do nothing about it and then either follow up with us like every year or at whatever interval just to check in. Um, and then for those patients that are really affected by it or would just like to get rid of it, there's an option for either daily medications, usually a beta blocker. I think in adults they tend to use calcium channel blockers, or an ablation procedure. So usually that's not, if SVT is happening in a younger child, like in a 2-year-old, like we have to wait a little bit before they're big enough to do an ablation procedure to either burn or freeze the area that's causing the arrhythmia. But usually we're able to do an ablation procedure, or the electrophysiologist is able to do an ablation procedure in even a school-age child. And the reason that we need them to be a certain size is that the catheters that we use to do the ablation procedure are pretty large. So you need them to be a certain size in order to fit them. So for ventricular tachycardia, so the definition of that is three or more beats that are occurring that are originating from the ventricles that are above sinus rate. Um, Technically, it should be about 20 to 25% faster than basal sinus rate, or in older um, children or teenagers, greater than 120 beats per minute. Uh, that is in comparison to a slower ventricular rhythm that is, less than 20 to 25% higher than basal sinus rate. That if that's seen, then generally that's benign and has a good prognosis. That's a little bit of a difference in terms of rate for ventricular tachycardia. In terms of signs and symptoms, so there are actually some patients that have ventricular tachycardia and are doing totally fine, are asymptomatic. Other patients are bothered by it, so they'll describe heart racing, palpitations. You might have dizziness, even fainting, shortness of breath, and then sometimes, usually in our channelopathy population, you can also have sudden cardiac death. There are a lot of causes of ventricular tachycardia. So, just to give you kind of like an overview of possible reasons why someone might have it. And then sorting it out by acute reasons and chronic reasons. So, in the acute reasons that you might have ventricular tachycardia. So, if there's, for example, hypoxia, any sort of acidosis, electrolyte abnormalities, that could lead to ventricular arrhythmias. If someone suddenly has coronary insufficiency, so for example, if the Kawasaki disease patient that had a myocardial infarction or something, that could also be a reason. Trauma, the ones that we see in our population is after cardiac surgery, ventricular tachycardia can happen because the heart is in an irritable state. Myocarditis can also have ventricular tachycardia, and then certain medications or obviously illicit drugs can also cause that too. Certain congenital heart disease lesions can also be a risk for that as well. So tetralogy of Fallot, a repaired tetralogy of Fallot is a good example of that. With that congenital heart lesion, for example, they'll cut through the ventricles, and that'll be a nidus for ventricular tachycardia. Any of our coronary anomalies might be another congenital heart lesion. Sometimes mitral valve diseases that might have associated ischemia can also cardiomyopathies, channelopathies. Those are also conditions that might have risk for ventricular tachycardia over a longer period. We don't see cardiac tumors too much, but that can also happen with them. And then there's also just idiopathic ventricular tachycardia that we sometimes see. Those tend to be, if they're occurring from the outflow tracts, they can be relatively benign as well, but they can be bothersome. So sometimes we do treat them. In terms of workup, sorry, I didn't mean to have this here, but for workup, again, getting a baseline EKG is helpful. Just looking at the myriad of different types of etiologies of ventricular tachycardia, I think it's worthwhile to start the workup for possible acute things. So if you're, for example, if you're worried about an infectious or myocarditis picture, you can send for certain labs that are related to that. It's worthwhile to look at electrolytes as well, I think. And then we can usually take over from there in terms of like cardiac rhythm monitors, whether there's a reason to do an exercise stress test or echo, an EP study if needed down the line, or even genetic testing. And the management would follow what you thought ends up being the possible etiology for the ventricular tachycardia. So addressing anything that might be reversible, looking into inherited causes, for example, like channelopathies. And then in patients that where it's bothersome or dangerous, like in ablation or even in ICD in rare cases. So that's our ventricular or our tachyarrhythmias. Moving on to bradyarrhythmias, so I'll just focus mostly on or exclusively on AV block. So we'll talk about first degree, second degree, and third degree. So for first degree atrioventricular block or AV block, so it's really to me a misnomer because there's no actual block happening. But basically what it is related to is prolonged conduction from the sinus node to the AV node, so prolonged AV conduction. So what you have on EKG is a prolonged PR interval that you can see displayed here. Typically, it's benign as long as it's in isolation. And the reason that some people may have that is because they could have increased vagal tone. So, for example, you'll see them have a first degree AV block when they have that increased vagal tone, and then they'll also have periods where they don't have a first degree AV block. Oftentimes they're asymptomatic, and this is an incidental finding. It could also be related to structural heart disease, infectious or toxic etiologies. In Hawaii, we commonly obviously see this in our rheumatic fever population. So, worthwhile to look into possible reasons why someone might have first degree AV block. Um, and then so again, typically it's benign and someone is asymptomatic and they don't have anything else going on. I think it's also reasonable not to do this, but you can consider a Holter monitor for the very rare chance that it is associated with higher degree heart blocks. But I don't think I personally, outside of rheumatic fever, I don't think I've had an instance, for example, where a cardiac rhythm monitor has shown first degree AV block as a presenting symptom to be related to higher degrees of AV block. It can happen though. And then if this is an isolated finding, then no treatment is needed. Second degree AV block, Mobitz type 1, also known as Wenke block. So we see this a lot too, especially in our heart rhythm monitors. So this is progressive prolongation of AV conduction that then leads to a drop beat. So you can see here on this EKG strip that there's gradual prolongation of the PR interval. So this interval here is longer than this one, and then there's a drop beat here. Um, so I will often see this while a healthy teenager is asleep. So it is very benign um, in that scenario. So if you pick up second degree AV block, Mobitz type 1 in a young person at rest, then usually it's a not so worrisome finding. I think it is worthwhile to get a Holter monitor if this is something that you incidentally pick up to evaluate for higher degrees of heart block. And to also look at heart rate with activity and make sure this isn't happening when they're trying to be active, because that could potentially be an issue. For Mobitz type 2 second degree AV block, so this is when there's an abrupt loss of AV conduction. So um, this is an example. So you can see a normal PR interval here, and then there's a sudden drop, a P wave buried in the T wave, and then there's a drop beat after that. So this is usually a pathologic finding, so can signify damage to the AV node or the His-Purkinje system right under it. Possible etiologies could be a cardiomyopathy, myocarditis, or other sort of infiltrative disease. Symptoms that could go along with it. So some people may be asymptomatic. You can also I've definitely had patients that have had dizziness, syncope, fatigue related to this. The workup would always start with the EKG for this, Holter monitor, and then an echo to also look at other sort of structural findings that are going on or functional issues. And then, if there is something that's reversible to treat, then, obviously we would treat that. And depending on the symptoms of the patient, there could be a need for a pacemaker. So for third degree AV block, so this is when there is complete dysynchrony between the atrial and ventricular beats. Possible etiologies. So I will sometimes see this in fetuses and children whose mothers have maternal autoimmune diseases like Sjogren's or lupus. Sometimes we'll also see this as a iatrogenic finding after cardiac surgery, such as with VSD repair. It can also happen in an infectious or inflammatory state, such as rheumatic fever or even myocarditis. Symptoms actually vary and it completely depends on what the escape rhythm is. So if you have a narrow complex junctional escape rhythm, and the rate isn't too bad, like in the 70s, 80s, like some people may not even have symptoms, and may be doing fine. Um, you can also have pretty scary symptoms as well. So you can definitely have heart failure symptoms. You can also have not which would include fatigue. You can also have syncope and even sudden death. Um, and then, as you might imagine, EKG, cardiac rhythm monitor, echocardiogram, looking into possible causes for this would be part of our workup. And then supportive um, care as appropriate for this. And then oftentimes the kids will meet criteria for a pacemaker if they have third degree AV block, but not honestly, not always. So those are some of our bradyarrhythmias. And then just to finish with PACs and PVCs. So for PAC, so these are atrial beats occurring before the expected sinus beat and not from the atrial tissue from atrial tissue that is not the sinus node. Um, Oftentimes they're conducted normally through the ventricle. So these are examples of conducted PACs here on the bottom. And then sometimes they can be aberrant. So this is also an example of a possible aberrant PAC. So you can see that the QRS complex is a little bit wider than the QRS complex here for a normal sinus beat. So that just means that it's not traveling through the AV node. And in some cases, it can also be blocked. So if the rest of the myocardium is refractory, then that extra PAC will come and then it's not conducted and you have a little pause there. Symptoms. So most people are asymptomatic. Some kids will be able to describe a skip beat. So what they're feeling is like the more forceful beat that comes after the PAC. Um, Workup could be EKG labs to look at, for example, electrolytes. We also sometimes place a cardiac rhythm monitor. And then if this is all that's going on in isolation, then typically we do not treat this. PVCs are a little bit different. So these are early beats arising from the ventricular myocardium. Generally, they are Y complex, but they can be narrow if they're occurring near the His-Purkinje system. People will often be able to describe palpitations, but sometimes a lot of my patients that have this are asymptomatic. Etiology, so oftentimes it's idiopathic and just occurring in a normal heart. And oftentimes, honestly, like we all have a couple of PVCs occurring for all of us from time to time. We see that in most of our monitors. Other reasons to have PVCs that are not so benign, cardiomyopathies, channelopathies, myocarditis. And in our clinic, we are trying to figure out what is benign and what is not benign for PVCs. So a brief list of things that are um, I guess maybe good isn't the best word, but like benign, I guess, in terms of PVCs. So if they're monomorphic, if they're coming from the same spot in the ventricles, then that's usually a good sign. So if it's polymorphic, that makes us think more of maybe issues, for example, with a coronary artery. So I have a patient that had a recent coronary surgery and has polymorphic PVCs, and that's a sign that he had some ischemia. If there is ventricular tachycardia also present, then that also increases the risk that goes along with PVCs. If they if they are suppressed with higher heart rates, so if they go away when the patient exercises, then that's also a good thing. And then if it's a lower burden, that's also goes along with a more benign presentation. If it's a higher burden, then and typically this is in the range of like more than 25% for like years, then there's a risk of having cardiac dysfunction. And that will drive our workup. So, sorting out whether things are good or bad. So, EKG, sometimes we're getting labs as well, just to look at things that could be reversible, like electrolyte abnormalities, usually in the hospital setting. Getting a cardiac rhythm monitor is also something that we'll do to help us quantify how much of a burden the PVCs have to also evaluate for ventricular tachycardia. And then we do get echocardiograms in this context to look at heart function, to also look to see if there's any associated structural heart disease. And then exercise, sometimes we can just do this with a cardiac rhythm monitor, but we also can formally evaluate whether PVCs are suppressed with higher heart rates with an exercise stress test. Um, and then so treatment. Sometimes we don't have to do it with most of my patients that don't have a high burden. They're monomorphic. PVCs are idiopathic. Um, then oftentimes we're just monitoring and not really doing anything. You can treat with medication such as a beta blocker, and then ablation is also possible for those patients that we think might have a higher, I guess, either more bothersome or dangerous form of PVCs. So some closing thoughts. So symptoms of postural arrhythmias are very common, which is difficult, I think, to sort out. But fortunately, in our pediatric population, most are not dangerous. I still think that a history examination and EKG are our most important tools to assess risk and to assess for whether an arrhythmia is present in our patients. And I think that is definitely within the ability of the general practitioner. Um, and we're always available for any concerns or any questions. That's it.
Thank you. That was great. Thank you so much, Melissa.